Hello, I'm Kathleen Digre, and I am thrilled to be with you here today. Uh, the first lecture that I'm going to be giving you is on headache. Headache is one of the most common symptoms that every physician will see. Either you will be asked about headache when you're going through medical school, or you will have headaches yourself, since 20% of women and 10% of men have migraine. And sometimes you'll give somebody a headache. So I want you to understand that headache is extremely common. 70 to 80% of all adults will have a headache sometime in their lifetime. 38% of children will also have headaches. 4% of office visits to doctors are for headache. This is more common than asthma and diabetes combined. And the World Health Organization has said that migraine, a primary headache disorder, is in the top of the 10 most disabling conditions in the world. Now, to understand headache, you have to realize that headache is really a history diagnosis. And so there are certain elements of the history that you have to take if you want to come up with the right diagnosis. And the first one is family history, because this really sets the genetic stage. Who is genetically vulnerable to get headaches and migraine? Many times, people will not know that their parents had migraine earlier in their life without asking. So sometimes one of the assignments is to go home and ask your parents who had headache in our family. Many families have sinus headache. Well, sinus headache, quote unquote, is often migraine. That study has been done. And so sinus headache usually means that there's a migraine. Then life history. So migraine and common headaches that start and are in primary headache disorders will have its roots in childhood. Sometimes even babies are thought to be colicky, and that's a migraine variant. But let's say car sickness as a child, night terrors as a child, episodic stomach aches as a child. And then often these headaches will start in adolescence. And then you want to know, when did they start getting worse? Was it around a stressful period of time like marriage, divorce, or death of a loved one? And have they changed over time? The most important part of the headache history is also the attack. What's going on in the attack? Is this a new headache? Nothing like it ever before. Is there a warning sign like an aura? An aura, and we'll be discussing that, is a discrete neurologic event that can precede a migraine in about 30% of individuals. Where is the headache located? The front, the back, right side, left side, or both sides? The buildup, is it sudden in onset? Sometimes that heralds a very secondary headache. Are there characteristics of the pain like throbbing, jabbing, stabbing? How often? Each month, each week, each year? And how long do they last? Minutes, hours, days? When does it occur? In the morning, the evening, or any time? And then the associated symptoms, because this will delineate what type of primary headache somebody has. Nausea, vomiting, photo, and phonophobia are really typical migraine symptoms, whereas lacrimation, rhinorrhea, eye redness, and ptosis are more with the autonomic cephalgias. And then factors that make it worse or initiate it or trigger it, like diet, something in the diet, no sleep, stress, menstruation, and things that make it better, sleep or some type of medication. Now, the attack itself has kind of an anatomy. There's what we call the prodrome, which can be like yawning, feeling tired. I've also got patients who say they never felt better. And when they have that feeling, they know they're going to have a migraine. Now, the aura may or may not occur. 30% of people get an aura before a migraine attack, and this is a discrete neurologic event, usually visual, before the onset of the headache, and the headache lasts 4 to 72 hours. And then afterwards, people can have fogginess in their brain, light sensitivity, sound sensitivity that may continue to last. We always ask about medical and psychiatric history because there are many medical conditions that can be comorbid with headache, like sleep apnea, chronic obstructive pulmonary disease, because both of these can cause carbon dioxide retention and headache. Thyroid disorder, 40% of people with thyroid disorders can have headache, anemia, hypertension, irritable bowel syndrome, asthma. And then importantly, psychiatric comorbidities, because these are increased in individuals with migraine, such as depression, anxiety, bipolar disorder, and physical, sexual, emotional abuse. I always ask about medications because not only do you want to know what medicines that person is on, but you want to know what herbal products they're on, over-the-counter medications, natural products, caffeine, how much caffeine do they take, sympathomimetics, and then drug use, cocaine, amphetamines, alcohol, marijuana, since some of these can cause headaches themselves. In the physical exam, blood pressure, heart rate, and a general physical exam should be normal. A complete neurologic examination be normal. And one thing you never want to miss is the fundoscopic examination, because you're going to look for papilledema or signs of increased intracranial pressure. Now, when do you get worried? When do you order tests and think, oh, maybe this isn't a primary headache, maybe this is a secondary headache? Well, you need to snoop. And snooping means that you have to be like Nancy Drew and start looking for clues. And some of the clues are ask for systemic symptoms like fever, weight loss, a systemic illness like cancer or immunocompromised host or HIV. Neurologic symptoms or signs, and these are important because sometimes migraine can mimic stroke. Onset, a fast onset, boom, less than a minute in onset, those are headaches you want to pay particular attention to because these can be secondary headaches. Older individuals starting to have headaches when they never had headaches before, major red flag. You want to snoop further to look for other conditions. A previous headache history, if they have no previous headache history and this is new, that's important. Or a progressive headache, something that just is completely different than their previous headache. A postural component, meaning the headache is worse when they're upright, better when they lie down, or vice versa, worse when they're down and better when they're upright. Pay attention to that headache. A headache precipitated by exertion or Valsalva. These can be associated with sinister headaches, secondary headaches. Pulsatile tinnitus, a whooshing noise. Transient visual obscurations, such as dim outs of vision, can be both signals of high intracranial pressure. And then anyone who has a new headache in pregnancy, you do want to look for secondary causes. What laboratory studies do we want to look for in individuals with headache? So imaging is often ordered for individuals with headache, and usually I order MR unless I'm looking for a bleed in the brain. However, when people go to the emergency room, a CT scan is often done to rule out an acute bleed, because that will be apparent on the CT scan, whereas an MR, an acute bleed may or may not show up. We also, in an older person with a new headache, we would get a CBC, a sedimentation rate, and C-reactive protein, because these will be abnormal in people who have giant cell or temporal arteritis. A lumbar puncture may also be done. And here you want to look for the opening pressure, protein, glucose cells to rule out a subarachnoid hemorrhage. Now, what causes headache itself? Well, traction or irritation of the pain-sensitive structures are important for the cause of headache. Distension of arteries, inflammation, obstruction of spinal fluid flow, and increased intracranial pressure, and involvement of the central pain pathways. So the system that causes pain in the head is called the trigeminal system. And that system is complicated because it has three divisions. It has the first division that serves the front of the head to the top of the head, the second division that serves usually the cheeks, and the third division that serves the chin and jaw area. The first division also has what we call the recurrent nerve of Arnold, which innervates all the meninges. So the dura, parts of the blood vessels, all those structures that I told you were pain sensitive are innervated by the V1. However, the trigeminal system is more complicated in that the trigeminal system connects to a whole spinal nucleus that goes into the upper cervical cord. And so that this spinal nucleus is involved also in pain processing. There are pain fibers in the facial nerve, the glossopharyngeal nerve, and the upper cervical nerves, and these can also participate in pain to the head. Pain-sensitive structures, as I said, are intracranial sinuses and veins, arteries and veins of the dura, arteries at the base of the brain, like the circle of Willis, parts of the dura mater, especially around those blood vessels, the skin, the scalp, the extracranial vessels, mucosa of our sinuses, and arteries are all innervated usually by the trigeminal system. Things that are pain insensitive are the brain itself, the ependymma, the pia, and parts of the dura mater and the parts of the skull. Some of the periosteum is pain sensitive. How do we classify headache? Well, I want you to understand that headache is classified into primary headache disorders. This means migraine, tension type, cluster headache. These are headache disorders that are associated with the brain, but they aren't caused by any external factor. Whereas secondary headaches are caused by an external factor, like a brain tumor, intracranial hypertension, temporal arteritis, subarachnoid hemorrhage, and trigeminal neuralgia. Now, we classify headaches according to a classification scheme brought up by the International Headache Society called the International Headache Classification Disorders. And this was started in 1988, revised in 2004. And the last one we had is the third edition is in 2018. We have guidelines for various headache types, both primary headaches and secondary headaches. Now, while these are research oriented, you can download this whole thing and put it onto your laptop if you're really interested on what specifies, what elements go in to give a specific headache diagnosis. Now, the most common headache type that we're going to be talking about is migraine. Migraine is an inherited headache disorder. It's a primary headache disorder. The central and peripheral nervous system participates in this headache and in the generation of this migraine. And there are multiple brain areas, as we'll find out in the next talk, are involved in the migraine process. So how do you classify? What are the pieces that need to be present for this headache to be present? Well, you have to have at least 5 attacks. The attacks last 4 to 72 hours. That means they can last longer than 1 or 2 days. And you want 2 of the following, either a unilateral pain, a throbbing pain, moderate to severe, worsens with activity. So 2 out of the 4. So it could be unilateral and worsens with activity. It could be moderate to severe and throbbing and be anywhere. And that would suffice that criteria. At least 1 of the following, nausea and or vomiting. As soon as you have nausea and or vomiting, it is usually migraine. Photophobia and phonophobia. So let's say you don't have nausea and or vomiting, but you have photo and phonophobia, then it's migraine. And here's an important caveat. It's not accounted for by another disorder. So now somebody could have a headache that sounds just like a migraine, but it has one of those factors that makes you think about a secondary disorder that you've snooped at, and that there might be something underneath it causing that secondary. So you can't just do this and forget your secondary disorders. You have to snoop and then figure out, is there a secondary headache disorder before you make the diagnosis of migraine? Now, there was a study done where they said, what are the 3 most important questions you can ask that will tell us that it's a migraine? And the one is, are you disabled by the headache? Does it cause nausea? Does it cause photophobia? And if you have 2 out of the 3, you will have a 93% chance of having the diagnosis of migraine unless it's not accounted for by another disorder. All right, we classify migraine into episodic, which means less than 15 days a month, and chronic, which means more than 15 days a month. And this is just arbitrary. Now, let me take you through this diagram. So here is an individual, a woman, whose mother had migraine before she was even born. She's born, and then she was car sick as a kid. She had some abdominal pains, and headaches started right around her menstruation, about 12 to 14. And then she got a job and she had a few more migraines. Then she got married and she had a lot more headache. And then she had a baby. And of course, she got a lot more headache after children. And then throughout her life, she would have periodic times when headaches would be worse, let's say after the death of one of her parents. And then as she got older, she went through menopause, and then her headaches seemed to dwindle off. And often what happens as people get older, they may not have the headache piece, but they can sometimes have an aura. And here's her attack. She was yawning, irritable, felt like she just was kind of crabby before the attack occurred. Then she'd get the onset of the headache with nausea, vomiting, and if she took her medication, which we'll talk about in the next lecture, she could abort the headache, and otherwise it would go on for several hours. And this is migraine without aura. Now, migraine with aura is very similar. Family history, car sick as a child, headache starting around puberty, and so forth. But the thing with aura is about a third of people with migraine have an aura that comes before the migraine. And this is usually visual, and it is a neurologic event. It's not yawning. It's not just feeling tired. It's not just feeling fatigued, even though those may be what are prodromal or telling the person that they could have a warning of a headache. But this is a discrete neurologic event followed by the headache. And this is migraine with aura. So migraine with aura is a fully reversible symptom, and it usually indicates a cortical dysfunction, as we'll find in the next lecture, or some kind of brainstem dysfunction like dizziness, vertigo. It usually develops gradually. Unlike stroke, which comes on boom at the sudden onset of a deficit, aura is more of a gradual buildup over several minutes. It usually lasts no more than 60 minutes, and pain follows the attack in less than an hour, usually. The aura can be not followed by pain, and that we call acephalgic, meaning no headache, or migraine aura without pain. Now, I mentioned that the most common aura is a cortical visual aura. And as you might expect, it starts in one section of the vision and moves out to another section. And it goes slowly. It starts as maybe a single spot, and then as this cartoon shows it, it often has this zigzag line of fortification spectra. Sometimes it can be a hallucination, like an Alice in Wonderland effect. Lewis Carroll, who wrote Alice in Wonderland, himself had auras, and many believe that the Cheshire Cat's teethy grin was from his aura, and that Alice in Wonderland's elongated neck was part of his visual auras. You can occasionally have aphasia as an aura. It'll start sometimes by just word finding difficulty and then move on to even more difficulty speaking, and then even word salad like Wernicke's aphasia. Those are less common, and often you have to rule out stroke. There is a kind of brainstem aura, which can be vertigo, which can precede the headache, and chiro, oral numbness. This is numbness. Chiro means your hand, oral is your mouth, and it's numbness and tingling around the hand and the mouth, and that's a typical brainstem aura, or double vision. And these are followed by headache, not associated with stroke. This is a city in, I believe, northern Italy with before World War II that had these nice fortifications. Remember, they used to build forts to preserve the inside of the city, and that's where the word came from. Here's a typical aura. This was drawn by one of the family medicine a resident that I worked with, and he drew his aura as little zigzag lines that were colored dots. They sort of sparkled, and then they got bigger and bigger and bigger and bigger and went off to the right side. So where would his aura be starting in the brain? It'd be starting on the left side of his brain, wouldn't it? And it would be kind of starting in the middle part of the calcarine cortex and moving in the tip of the calcarine cortex and moving out into the periphery. Now, cluster headache is the one headache that is more common in the men. There's sometimes a family history, but not always. And these usually start in the 20s, and they're called cluster because they seem to occur boom, boom, boom in the spring and the fall, clustering around the equinox, the autumnal and spring equinox. And they occur numerous times a day. And then you get a remission, at least an episodic cluster. But they can go on through a person's life. The attack history is completely different than migraine. It's always, almost always, on the same side every attack. It increases, it's unilateral, always. It has autonomic features like sweating, tearing, flushing, runny nose or rhinorrhea. You can have a Horner syndrome on that side. And it wakes you up in the middle of the night, and it only lasts maybe an hour to an hour and a half. And you can curtail it with fast-acting medicine, but usually by the time oral medication comes along, it's already gone. And we'll talk more about treatment of cluster headache with oxygen in the next lecture. Now, cluster headache is always severe. It's kind of called the suicide headache, and the pain can be over the orbit in the temple and can last 15 to 180 minutes. And it always has one of these autonomic features: conjunctival injection, ptosis, facial sweating, eyelid edema, a Horner's syndrome on one side, the same side as the pain, lacrimation, nasal congestion, rhinorrhea, and again, not accounted for by another disorder because cluster headache phenotype can be mimicked by other things like pituitary tumors and the like. When I see somebody with cluster headache, I always look for a Horner syndrome. This young man had a Horner syndrome on the left and his cluster headache was on the left, and sometimes it can be permanent. Cluster headache, as I said, comes from the cycling of the attacks in spring and fall, awakens people in the middle of the night, and it's episodic when it has remissions in between. And the unfortunate men and women can get cluster too, that are chronic, meaning there's no remission. Those are people that really do suffer because they get no breaks. The cause of cluster is thought to be generated in the hypothalamus, and we'll talk about that in our next lecture. Now, what about episodic tension type headache? Many of you probably have had a tension type headache. This is a mild to moderate, pressing, non-pulsatile, never throbs, usually bilateral, and you can take a run with it and it doesn't make it worse. In fact, it can make it better. And the headache has no nausea or vomiting at all. So as soon as you have nausea and vomiting, you have migraine. If photophobia or phonophobia is present, it's only one of them. So you could have a little light sensitivity, but no sound sensitivity. Or you could be sound sensitive and not light sensitive. And there's no cause of a secondary type of headache. So you still have to snoop. Is this a tension type headache phenotype, but it's being caused by a brain tumor, for example? So it's important to understand that you always want to rule out that secondary headache type. It's often thought to be the most common headache type, but it is not common for individuals to go to their provider with a tension type headache. Usually these are mild, they're nothing, you ignore them and they go away. Again, we classify them by episodic, less than 15 days a month, chronic, more than 15 days a month, just arbitrarily. And it really doesn't have anything to do with tension or muscles. It may be related to migraine. Some people feel like there's a continuum where you have this tension type headache or a tension vascular type headache, and then you have more severe headaches with all the other features of migraine. And some people believe that they're separate entities, but we don't understand tension type headache as much as we have begun to understand migraine. Now, I'm going to shift gears to secondary headaches, which are due to underlying processes. And remember, this is going to be an effect of inflammation on blood vessels, the effect of pressure on blood vessels and the brain, high or low pressure, the effect of infection, which inflames the meninges, which is pain sensitive and will be experienced as a headache. We'll talk about sinus headache and a couple neuralgias where the nerve itself is injured or not or irritated. Remember to snoop on all of these secondary headaches because the clues will be there. For example, this lady, 75-year-old woman, she used to have migraine. The migraines went away and she was completely headache free for many years, ever since her menopause at 50. She calls her doctor up and says, you know what, I've got a new headache. It's in my head all over, it's pressing. And the doctor said, oh, it sounds like a tension type headache. Have you tried an aspirin? The next call the doctor gets is that she's blind in her left eye. And that's because she has temporal arteritis. Now, this is usually present in patients over 60. The pain is sometimes nondescript, kind of like a tension type headache, bitemporal. Maybe it's severe. There may not be light and sound sensitivity or nausea or vomiting or anything like that. The key is that the sedimentation rate is elevated and the C-reactive protein is elevated, and they may have other symptoms like pain. Chewing their food is one of the most sensitive symptoms that somebody can have. Aching in their jaw, unexplained weight loss, or anemia. And it can cause blindness. So it's a very serious headache that you don't want to miss in an older person. Now, this woman presented to me with the story that she had pinwheels up in her left visual field going on continuously. And her primary doctor had said, well, it sounds like a migraine aura. Do auras last continuously for days on end? Well, there are some persistent auras, but this is, and here's the other factor. She has a new headache. And the new headache is a tight feeling in the head, and it's moderate, gets worse when she lies down, when she coughs, sneezes, and has a bowel movement. So she had, if you snoop, she's got a new headache with new neurologic events, and she's got weird positional changes with it, and coughing, sneezing, bowel movements make it worse. She's got like 5 snoop criteria for a secondary headache. Sure enough, this woman had a new headache starting with neurologic symptoms, and her headaches were kind of coming periodically, but they were kind of nondescript. But when she coughed, bent forward, exercised, even lying down gave her a headache. So this is a headache that we imaged, and this actually turned out to be a metastatic colon cancer in a young, otherwise healthy woman. So brain tumors, the typical headache can waken people in the middle of the night. It can be side locked, but you know what? The most common headache type with a brain tumor is often a tension type phenotype. Sometimes people can have projectile vomiting. You always want to look for papilledema. You always want to look for pulsatile tinnitus or whooshing noises in the head, headaches that come on with cough. If the imaging is normal, sometimes you might have to do a lumbar puncture to check the opening pressure because maybe it's idiopathic intracranial hypertension. So idiopathic intracranial hypertension is a woman's disorder, 6 to 1. It's as common as multiple sclerosis in obese women. It causes headaches, bad headaches. It also causes visual obscuration because the papilledema sort of transiently affects the vision and gives a dim out of vision. And you can see papilledema, and you can also see changes in the visual field. Here we can see an enlarged blind spot with some changes in the visual field bilaterally. You often have to do an MR scan, a magnetic resonance imaging scan, to rule out a tumor or venous sinus thrombosis, which can present almost identically to this. And you do a spinal fluid exam to get the opening pressure. It often will improve with weight loss and diuretics such as acetazolamide. But this is an important one to know about. What about low pressure headaches? So these are people that come to you saying, And it can happen after a lumbar puncture. So when you do a lumbar puncture in someone, you always want to ask about headaches that are positional, worse when they're upright, better when they lie down. A very common cause. However, some people can spontaneously have a low pressure headache, and this will be characteristically that if they lie down, the headache gets better or gone, and when they're upright, the headache is worse. And there'll be imaging findings of low pressure, like low-lying cerebellar tonsils, squishing of the midbrain and also the pons against the clivus, and plumping up of the pituitary. Also, you can see signs of meningeal enhancement that are coming because of the low pressure. So this is a very typical finding of low pressure headache. Now, another headache I don't ever want you to miss is a sign of meningeal irritation or from a subarachnoid hemorrhage, or there are other vascular events that give this kind of headache. Sudden onset of the worst headache of one's life is a subarachnoid hemorrhage or a bad headache until proven otherwise. It can be a sentinel sign of a subarachnoid hemorrhage, as seen in this individual. This person went to the ER and said, I was just sitting there and I had the sudden onset of the worst headache of my life. And the only clue was this little white dot between the midbrain peduncles. And you may not see a stiff neck. You have to do a CAT scan to look for blood. And if that's negative, you may have to do a lumbar puncture. Now, what about meningitis? Well, this can present with fever, stiffness of the neck. It's one of the most common causes of what we call a new daily persistent headache. It's a headache that comes on one day and it just never gets better. And you really do have to do a lumbar puncture after an imaging study to rule out a meningitis. Now, sinus headache is really overrated. Sinus headaches do occur. If you've had a really, really bad upper respiratory infection and a cold and your sinuses have been aching, you've experienced a sinus headache. However, it really goes away after the cold is over, and it's not periodic. Like, you don't get a sinus headache once a month. So they've done a study where they took 100 people who said they had sinus headaches, and they found that only about 70% to 80% of those people actually had migraine, and maybe 20% had some kind of sinus disease. 20 to 30% had some kind of sinus disease, but most of it was migraine. Now, how do you recognize a neuralgia? A neuralgia is when a nerve itself is injured, and the trigeminal neuralgia is the most important one. The most common place for the neuralgia to occur is in the cheek or right by the inner side of the nose, and it makes people go to the dentist thinking that they've got a bad tooth. Now, the key about the next most common is up by the eye and forehead, above the eyebrow, and then in the chin. Now, the pain itself is different. It's a staccato-like pain. It's short bursts of pains, boom, 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 boom. And it's often caused by triggering it. So I have had patients who say, I have this pain right here, and they point to their nose, and they don't even want to talk because that could irritate and cause that volley of pain that they get, and they never want to touch that part of their face. So if they're messing around with their face and everywhere, it's unlikely to be typical trigeminal neuralgia. These are triggered by touch. In young people, one of the most common causes is multiple sclerosis. In older people, a vascular loop can go up and hit the trigeminal nerve as it's going into the Gasserian ganglion from the pons, and can give them trigeminal neuralgia. Occipital neuralgia is a pain in the back of the head. In the occipital nerve, this comes off of the C1, C2, C3 areas, and it forms a nerve that comes up the back of the head. And it's easy to injure because it's kind of out there in the middle, and it will create a stabbing pain that goes from the back of the head to the eye, usually. And often over that area, if you tap that area, you can reproduce the pain. That's a Tinel sign over the occipital nerve. I do want to mention one very important type of headache to never miss, and that's herpes zoster ophthalmicus. You know, it's the zoster virus that all of us have gotten vaccinated, hopefully chickenpox virus, but it can live in your Gasserian ganglion, and then it can come out periodically. Headache is the heralding event, and people come in with a new headache. It's deep, it's boring, it's new. They've never had a headache like this before. The MRI scan is negative, and maybe several days later, they'll get a rash that will come out, and it may not be as dramatic as this one. See, this one is very dramatic around the eye into the tip of the nose. And if the tip of the nose is involved, the ciliary division of 5 is involved, and that's called Hutchinson's sign, and it's associated with the worst complications of zoster. Well, I hope this has been a whirlwind trip through headache, both primary and secondary headache disorders. Believe me, you're going to be thankful that you know something about headache, because it's everywhere. Remember, it's in the top 10 most disabling conditions. It's one of the 5 most common reasons somebody sees their provider. And I can't think of a single specialty where you're not going to encounter headache in your chosen practices. So download that International Classification of Headache Disorders onto your computer, and you can have some pretty cool late night reading. We'll see you in the next lecture. Thanks.